Hello everyone, my name is Boris Karaman. This video is filmed for Nursing Class 4010 at Capella University, and it is about collaboration and leadership reflection. I would like to thank Dr. Linda for teaching us in this course about how to lead people, processes, and organizations in interprofessional practice. Background story. I am very passionate about my patients and their readiness for discharge to their previous place of living in stable health condition with all necessary equipment in the best physical and emotional state they can be, strong and happy. My personal reflection that I will share with you describes a chain of events that occurred within the interdisciplinary collaboration during Skilled Nursing Home, or SNF, weekly multidisciplinary care team conference related to discharge planning. I would like to make a note that interprofessional collaboration is a critical aspect of my work as a nurse in preparation of a patient's discharge from the facility to home or board care. By the way, at my workplace, we call traditional patients residents, as many of them live with us for a long period of time until they can really prove health progression and become ready for discharge. As a registered nurse MDS coordinator, stands for minimal data set, my job is to serve as a connecting bridge between several teams to organize care conferences in facilitating the dismissal of our residents where the discharge goals are discussed, projected, set, and carried out. The healthcare teams involved in this process include non-clinical members such as social services representative and activities director, as well as clinical participants such as rehabilitation manager, physical, occupational, and speech therapists, dietitians, and a case manager nurse. In this case, it's me. Through our interprofessional collaboration, the above-mentioned individuals and residents share information and consider each other's perspectives during our meetings to better understand and address the many factors that contribute to the health and well-being. Sullivan et al., 2015. The interdisciplinary team, or IDT, at my job usually asks me to help them identify the most appropriate date and time for the care conferences to be scheduled in order to conduct mandatory discharge planning meetings and discuss residents' health progress and concerns before they discharge. The electronic Microsoft Outlook calendar with attached notes is used to choose and set available dates for our meetings and to identify convenient locations that suit best the condition of the resident, depending on their level of functioning and independence. In addition, we use PCC, point-click care system, to notate patient care activities, generate latest healthcare reports, and view other diagnostic results to also screen for allergy and drug-to-drug interactions, check for recent falls, identify infection risks, and to review physical rehabilitation potential for every resident who is anticipating discharging. Each time before conducting a meeting, all of these aspects should be looked at and updated by each team member for all of us to be ready to discuss the progress with the resident and their families. All attendees need to rely on each other to provide most current and accurate resident healthcare status information and be prepared to set the goals of care with future projections for discharge, along with noting the regression, if any. Essentially, by collaborating, healthcare professionals and residents can have better health outcomes and have a proper discharge plan in place. As the MDS coordinator, I am often at the front line when interacting with various clinicians, non-clinical staff, and medical records, fulfilling a partnering role and interdisciplinary approach to healthcare improvement in preparation for residents' discharge. However, if any of the IDT group members come unprepared or express poor engagement, it causes anxiety, frustration, and has the potential to impact patient safety after the resident's departure from the nursing facility. Because of this, all attendees are expected by me to always be available to attend discharge care conferences during chosen times that are being discussed in advance and be prepared to operate at their peak performance in front of the resident and their family members to prove our high standards and quality of care. Another job for me as a coordinating nurse is that I am required to perform periodic spot checks in addition to the regular daily checks on the health status updates being provided for me in PCC as a summary to maintain other team members' reliability and performance. The IDT team is also advised to speak with my manager, who is above me, Director of Nursing, if any special accommodations are needed for the resident to arrive on time for the discharge care conference, such as wheelchair, or contacting their family in advance to receive special permit to enter the building due to the worldwide COVID-19 visitation restrictions, to discuss the discharge planning goals. Given the time of pandemic, my team is expected to anticipate that the discharge meeting begins at exact scheduled time online, via phone or by video, and the family is connected over the working tablet with the correct phone number or email address. The social services representative is assigned to make sure the resident and the care team on one side of our multidisciplinary discharge care meeting are in by calling the family members on the other side to check if the connection actually works. Social services are also responsible for notifying certified nursing assistants, CNAs, to help patients be ready on the day and time of the discharge planning meeting. If these tasks were not performed by social services, there was a great risk that the entire dismissal-related care conference would be jeopardized, with the family being unreachable, ultimately resulting in the inability to conduct the meeting and share any resident information on their progress and discharge plans. The IDT members would need approximately 10 to 15 minutes to go over the health updates with the resident and the attending party on the other line. The rehabilitation manager is tasked to work with their physical, occupational, and speech therapists in advance to determine current functional levels at which the resident is performing, create an attainable discharge plan from rehab services, identify sources to provide support for the residents pre, during, and post-rehabilitation, provide necessary equipment and educational materials to the family upon discharge, and come up with a short questionnaire to conduct a brief interview from the resident and representing family to identify opportunities for improvement in residents' current health status once they discharge to their previous place of living. Keeping in mind that all interdisciplinary departments impact the flow and duration of the discharge planning meeting, I realized that I need all members of IDT gathering to be engaged promptly to determine tentative date and time for a resident's discharge. Therefore, the next multidisciplinary member who contributes to a successful ending of the meeting is a dietitian. The dietary objective is to identify readiness of the resident related to their nutritional needs. The dietitian is expected to analyze any possible obstacles that could result in lack of access to food services or obtaining necessary calories after discharging from our facility, where they were closely watched for any nutritional needs by monitoring weight changes. This is another great opportunity to see interprofessional collaboration in action by implementing the dietitian's input on providing the residents who have low income by signing them up for participation in free nourishment dietary programs such as Meals on Wheels or CalFresh. The published evidence would support my idea of multidisciplinary or interprofessional collaboration. Quoting from 2010 publication, Concept Analysis of Interdisciplinary Collaboration by Dr. Laura Petrie. Interdisciplinary collaboration is commonly described using terms problem-focused process, sharing, and working together. The elements that must be in place before interdisciplinary collaboration can be successful are interprofessional education, role awareness, interprofessional relationship skills, deliberate action, and support. Consequences are beneficial for the resident, the organization, and the healthcare provider. End of quote. Planning. Before each discharge care conference takes place, our IDT meets together on Mondays at 9 a.m., including same attendees I described earlier in my video. Here we plan on addressing main health issues that could hold a resident from leaving the care facility and go home. During these gatherings, the interdisciplinary team leaders explain the needs and verify readiness of the patient discharge plan, including follow-up long-term benefits for the resident even after the dismissal process. Once the IDT meeting begins, all team members share their opinion about critical patient care milestones that pertain to their area of expertise since admission. The IDT participants explore the pros and cons of a variety of factors that could hold the discharge to occur for the chosen resident in the upcoming week. As expected, there is no day or time that fits ideally for dismissal from the SNF, as it depends on many factors. The most influential are patient clinical readiness, the availability of transportation, family members or legal representatives, prompt delivery of necessary for discharge medications and equipment, etc. However, realizing the need and importance of the upcoming discharge event, the IDT members usually agree that the most attainable discharge day and time is on Thursdays in the afternoon. The selection for such date and time was studied and offered by me as a coordinator for the following reasons. It allows last day shift rehabilitation sessions to be performed and confirm the level of functioning of the resident, such as self-feeding, grooming, basic hygiene, toileting, dressing, bathing, bed mobility, transfers, and ambulation. It permits the social services team to schedule transportation for the afternoon pickup. It gives enough time for the activities department to perform their morning rounds in making sure the residents started collecting their personal belongings, clothing, and electronic items. It allows the dietitian to make diet adjustments and set up necessary food services by making phone calls and faxing required documents in the morning time. And it gives the MDS nurse, myself, enough time to review all final details in the resident's chart in PCC to make sure there are no nursing needs that could prevent the resident from going home on the scheduled day pertaining to medication management, oxygen needs, presence of behaviors, IV lines, wound care, education, along with insurance verification. Actual discharge conference. Now I would like to discuss the very last interprofessional meeting we had at my SNF. On Monday at 9 a.m., the IDT members were gathered to discuss and implement the final discharge plan, and one of our team members was late. Arriving 10 minutes into the meeting, the rehabilitation manager apologized, saying she was behind due to the delay in treatment for a difficult patient. While waiting on her input, the team has already started reviewing latest health reports, documents, and started to discuss patient readiness to discharge. All of that needed to be repeated again so that the rehab manager was informed. In the meantime, the social services representative was trying to connect with the resident's family, rebooting the specially assigned for video and teleconferences tablet. She could not make it work, so she apologized and asked for permission to step out to switch the tablet to a new one, as this one had connection issues. After about 15 minutes, she returned with a working tablet and was ready to connect us. Now we're all waiting for the resident who did not show up on time. When paged nursing station over the intercom asking nursing staff to find out what was going on, the shift supervisor said that the resident will be there shortly, as the CNA had to take him to the bathroom first prior to coming to the meeting. All these obstacles consumed close to half an hour as opposed to scheduled 15-minute meeting. Luckily, the family was waiting all this time for us to call them, as when finally all of us were present, the family answered the call and jumped into the meeting readily. From here, the discussion went well, with one exception that the resident was newly diagnosed with diabetes and kept refusing to switch to sugar-free diet. The dietitian did not mention having this issue before, even though she said it was happening since admission. I have to stress the fact that providing such last-minute update on the change in residents' food preferences that affects his well-being can have a negative impact and push the discharge target date further. Fortunately, the family member on the phone was a significant other to the resident, and she assured us not to worry about residents' food preferences issue, as she is willing to take all the responsibility in making sure that the diet instructions will be followed strictly. The team agreed, but offered weekly follow-up sessions upon discharge, and the family was let go. After confirming and setting up the pickup time for discharge, social services representative discovered a progress note in PCC stating that the bedside commode will not be delivered to the resident's house today. Instead, it should arrive tomorrow. Immediately, the team called the family and brought them back on the line to discuss the issue. Resident's family was not concerned, stating that they have enough help at home to survive through one day without the commode. The meeting ended around 10:05 a.m., 50 minutes later after allotted usual time. Post-discharge debriefing. The next day on Wednesday at 10 a.m., we had our weekly staff meeting. I asked the IDT participants from yesterday's discharge planning gathering to stay for a brief moment to discuss the best practice leadership. All multidisciplinary team participants knew that we had to meet to review and study the issues we encountered yesterday during the discharge call with residents' family. The debriefing activity is supported by the authors Dufresne and Young, 2014, who say that, quoting, "Debriefing or guided reflection follows the concept of reflective thinking, providing learners with the opportunity to consciously review their actions, during and after an activity or situation. End of quote. I led the discussion by thanking everyone for being proactive in resolving arising problems before, during, and after the CARE conference. This is the best practice when the interdisciplinary team members identify themselves what worked well and what didn't. The rehab manager offered to text message everyone next time to let us know if she would be running late. The dietitian was encouraged to delegate diabetes-related issues to nursing and communicate from the beginning about the diet issues and food preferences of the resident. I motivated the team to keep resolving the difficulties as quickly as possible, explore opportunities for improving by notifying the rest of the team in advance if someone cannot make it, and summarized our reflection upon lessons learned towards possibility of non-working technology or delayed equipment delivery that may result in additional financial burdens to the facility. The debriefing went smooth and productive, with no one leaving the room offended. Villa Health Reflection. Lastly, I would like to share some thoughts about the Villa Health simulation by answering the questions from the activity regarding an interprofessional collaboration and how it could have been better approached. Question 1. What are some of the ways in which staff collaboration failed in the implementation of the HER? Lack of proper planning, poor training, lack of support, and ignoring concerns from staff and IT were among the greatest issues. In addition, the computer platform was not properly set up to manage patient care needed for the facility. Many of the available functions were considered unusable or inapplicable, which made the complex system harder to use and slowed all other processes in care delivery from nursing staff. Lack of communication and proper addressing the arising issues led to discordance among staff, along with poor use of the system that could have endangered patients' lives. Question 2. What could have been done differently on the management side to facilitate better collaboration? More efficient planning, more fervently working to address the problems and concerns, showing encouragement by collaboration and communication could have facilitated smoother transition and better process. Having the skills of leadership and organization could also have changed the attitude and outcome of the implementation of the new computerized system. Question 3. How about on the care staff side? The care staff was not prepared for the new technology. Their resistance to the changes did not help to facilitate the transition. They need to build the ability to support each other and work together to better manage the issues in software of the new program. They also could have worked as a team to address the numerous problems and had a more receptive approach to the implementation of the new product, as it was unavoidable. Thank you so much for watching.